little bit longer, so I'm going to do the best that I can. By talking to you a little bit about OPAT, hopefully some of you are somewhat familiar, but if not, I'm going to try to motivate you to be interested in focusing on stewardship opportunities at the transitions of care that we have for our patients. I have a few disclosures, an industry-related sponsorship as a co-investigator for an OPAT project related to immunocompromised patients, as well as an advisory board position related to antifungal agents and fungal infections. I will be discussing none of these at all the rest of the presentation. Okay, so again, what is OPAT? Hopefully many of you are somewhat familiar with the topic in general, but it's essentially the use of IV antimicrobial therapy administered in any outpatient setting whatsoever. So most commonly a skilled nursing facility or in home health, but certainly we've also done a lot of other more creative supported patients through other creative situations like in correctional facilities, when they've moved states away, certainly our transplant and immunocompromised patients who sometimes live at a distance. It's really trying to facilitate and be flexible to provide support for those patients to have their IV appropriate outpatient therapy done correctly and effectively and without unnecessary adverse event. So to that end, the reason why this is a specific thing that we kind of worry about and consider separately from other types of stewardship is that it has unique risk. And I try to emphasize 3 different points of risk that are a little bit different than other things. So there's institutional risk for the institutions where the patients come from. Obviously, readmissions are a significant, there's significant downside to readmissions, both from obviously a patient perspective, but also from the institutional financial perspective, as a lot of those readmissions are going to be unpaid or unreimbursed. There's provider risk to the provider who's doing that IV antimicrobial therapy, especially if that provider is not an ID specialist or they don't have the adequate support as an ID specialist to provide that therapy. They may not have adequate monitoring support wherever they are. They may not be familiar with the most appropriate monitoring that should be done. And so that's a risk to the provider professionally if that therapy is being provided on their behalf in an unsafe fashion. And then finally, obviously, the patient risk. So when we have unnecessary or inappropriate antimicrobials used, obviously the patient can be at risk if those are done inappropriately and they then therefore lead to that patient's poor outcomes. So I want to start out with a little clinical vignette to give you an idea about how stewardship in OPAT can be really impactful. So this was a situation not long after we began our OPAT program with an unhoused patient who had no resources, no insurance, and had been admitted for MRSA bacteremia and osteomyelitis, requiring 6 weeks of antibiotics. So the ID team came, they recommended 6 weeks of IV vancomycin, they signed off the patient. Over the next week or so, while social work and our care transitions team was working to try and get that patient discharged, because of all the reasons that you might imagine, they weren't able to eventually determine a safe discharge plan for the patient. And the default kind of plan in that circumstance was that the patient would just stay as an inpatient to complete their 6 weeks of antibiotics. Because at that point we had an OPAT program, somebody who was watching over the patient in the situation, we were able to identify that this stalemate had kind of happened in the patient's care and intervene, recommending a different course of therapy to allow the patient to receive outpatient dalbavancin to complete their therapy course, 2 infusions 1 week apart, as we do now for osteomyelitis in some cases. And in addition to that, because the OPAT team had that support and the knowledge of what to do, they were able to apply for and receive manufacturer patient assistance in order to pay for the antimicrobial therapy that the patient used. So not only did that not lead to any cost for the patient, they received an appropriate course of therapy, and it also avoided at least 10 and up to 38 days of inpatient hospitalization, depending on when you might have determined that the patient could have safely left on oral therapy. So I think we can all probably agree a pretty impactful intervention, and we'll talk more about these kinds of situations again later in the presentation. So with respect to OPAT, I like to divide it into 3 different stages to give you an idea about, at least for our OPAT program, how we work and what we're focused on. So first is in the acute inpatient phase. So this is prior to the patient discharge, and really as early in the IV antibiotic course as we can possibly be involved. We try to get involved and evaluate some of these items that you see here. So is the situation appropriate for OPAT? trying to kind of ensure that the plan from the very beginning, once we know what the definitive plan is going to be, that it's the plan for discharge is being smoothed out so that the care transitions folks know what the regimen is going to be, that the current plan for the patient, whether it's to go to SNF or home health or wherever, is going to be appropriate. The insurance is going to be sorted. And so we get that so that there's a very smooth glide path to discharge for the patient. Once the patient's discharged in the transition of care, there we really try to focus on communication. So this is where I would say the vast majority of our impactful interventions happen because of how many really unfortunate communication breakdowns there are in different types of transitions of care. So we've identified a number of situations, specifically when patients transfer to SNFs, when patients transfer to very distant sites of care, be they home infusion companies that aren't used to working with our OPAT program or other local facilities in our area. We do extra touch points to ensure that there's communication, that the plan that we've set out for the patient is what they have and they understand also not only what the plan is, but then that they can come back and communicate with us if there's any questions or issues. And then finally, in the ongoing ambulatory phase, this is where we're trying to, first of all, do ongoing monitoring for the patient, ensuring that labs that are necessary are received, doing any therapeutic drug monitoring that's necessary, and then again, in terms of impactful interventions, identifying any adverse events before they occur or as early in the adverse event process as possible in order to turn readmissions into instead perhaps ED visits or even better telehealth visit or something else that's less difficult on the patient and less impactful on the healthcare system. And then finally, we'll have the occasional readmission, of course, as we'll see, and having the OPAT program in place really also helps to improve the communication back to the inpatient setting of care because we usually have a very comprehensive idea about what's been going on in the outpatient setting and can communicate that to the inpatient team. Some things are often not in the chart or they're in a chart from another hospital or in some other place that's less readily available to the team. So these are the ways that as an OPAT team we try to work on these issues. So I mentioned early up front ensuring appropriateness of OPAT therapy. So I want to kind of quickly put in a plug for just some of the basics of stewardship. What we're thinking about is what are the indications for OPAT at all? And we have a nice guideline on our OPAT website, which is on the Antimicrobial Stewardship website for Nebraska Medicine. And what you'll see here are really we have a document that lists all the different infectious disease indications. And these are really the only 4 that we call out as generally appropriate for OPAT. So intra-abdominal infections without any appropriate source control, complicated surgical site infections, bone and joint infections, and endovascular infections. So the things that are not on here are things like skin and soft tissue infections, pneumonias, UTIs, things where we have a ton of data really at this point that for definitive therapy, oral antimicrobial therapy is really the gold standard that we should be using. And hopefully, and these are all, this guideline is written out with a lot of that evidence embedded in it so that we can demonstrate to our providers or when we're having discussions about what's appropriate, we can point them back and say, you know, in this case, your pneumonia patient really could benefit or would, here are the data to demonstrate that oral therapy is really the most appropriate care for these patients. And even so, with these, as probably many of you are aware, bone and joint infections as just one really good example, we're having increasing evidence that that's also an indication where we can utilize oral therapies effectively. And it's called out in here and sort of saying, well, we may not have as much clinical experience doing it, the evidence base is turning in that point. So we try to update these guidelines to provide good evidence-based care and again, to provide good support for our recommendations. Okay, so this is a slide I hope to kind of communicate what are some of the OPAT team interventions that we make on a regular basis. Again, many of them you'll be familiar with or I've already kind of alluded to this point, but I want to also emphasize or probably call out that there's a huge amount of overlap and they're really almost identical to just interventions that we make in antimicrobial stewardship in general, right? So changing patients to COPAT or oral therapy, utilizing long-acting antimicrobials when that's a more appropriate approach, de-escalation of therapy. So these are all just general stewardship opportunities. So really OPAT can be seen as stewardship just at a different point in care, right? So what the regimen might have been appropriate, and when the ID pharmacist was on the team reviewing patients early in care when the plan was being set up, may not be appropriate right before discharge when other things have happened and there's other changes to the patient's status or to their discharge location. And so it's really just re-evaluating all of those stewardship opportunities at the time and through the point of discharge. So one thing I want to point out is that in OPAT, it's one interesting place where sometimes we end up escalating therapy, and that is actually the more appropriate or important intervention that we can make for patients at the point of discharge. And so this reminds me of a really good sketch by Dr. Glaucomflecken. Probably many of you are familiar with his work, so if you're not, you should be. He is an ophthalmologist in, I believe, Oregon, who does a lot of parody work with the medical community, or parodying a lot of us in medicine and our different proclivities. And so he has one skit that's called Bill Orders Antibiotics. And so Bill is the guy on the left here. He's a poor medicine intern. He kind of, sadly walks up to the antimicrobial stewardship pharmacist and he's like, I really need to order meropenem for my patient with a fever. And of course, the antimicrobial stewardship pharmacist, being the good steward that they are, rebuffs him. And of course, there's some liberties taken because we would never, degrade or demean the physician, but he does that a little bit as well. And so sends him on his way, without any, recommends ceftriaxone, actually, wonderful job. So then in comes the super cool ID physician, and he says, I need all the meropenem for my patient. And of course, the antimicrobial stewardship pharmacist readily assents and gives him his meropenem because he's certainly well thought out the plan. And so this is what I'm thinking about when in OPAT, we're often presented with a patient who's ready to go to discharge. Maybe they're on a regimen like, Q8 cefepime and Q8 flagyl to go out, and not the most, easy regimen for a patient to accept and to take in the outpatient setting. And so in that situation, we'll recommend ertapenem as a once daily IV push, quick and easy. So again, it seems a little bit odd, and we are starting to have more and more, we're starting to collect and really as a community try to identify and be able to quantitatively measure the way in which this is really a good idea. I have a colleague who says that the most ineffective antibiotic is the one that the patient doesn't ever take. And so that's the kind of situation where you have these complicated regimens, patients are just not going to be able to adhere to them sometimes in the outpatient setting, and that's where giving the more broad spectrum, simple antimicrobial is really the better option. So I recommend this. Check out this video if you have a chance. So another situation, and I want to kind of go off from IV therapy for just a second to call out that there's opportunities all around, no matter what the setting is or how complicated patients you see. There's a lot of opportunity and interest in just looking at antimicrobials at discharge, not just IV therapies, but also oral therapies of all sorts. And so what you can see here, I've collected just a number of papers from quality journals just from the last 2 years, all of them evaluating patients going out on antimicrobial therapy, often oral, and looking at what the opportunities for de-escalation, shortening of therapy would be, and also a number of interventions that have actually been done and demonstrated effectiveness. And in the vast majority of these studies, you'll note that they are done in community hospitals, not in large academic centers, and they're also not done with ID specialists, trained pharmacists, or physician teams. It's pharmacists or other care professionals who are just doing thoughtful evaluation of the patient at discharge and then asking the right questions about appropriate duration and spectrum of therapy. So I like this quote by Arthur Ashe, which kind of demonstrates that, start where you are, no matter what your setting is, what your resource situation is, and use what resources you have and do what you can. So you don't have to be, making the biggest or most impactful intervention, and these studies can give you a lot of examples of ways that you can incorporate some of these concepts at discharge. Okay. I'm going to now go through a couple of our metrics and outcomes from the early part of our OPAT program introduction in order to give you an idea of some of the impacts that you can have by really focusing on OPAT patients and those. So these are the outcomes in red, both the pre-cohort, so the couple of years prior to the OPAT program being implemented. We looked at the all-cause 30-day hospital readmissions for patients that went out of our hospital on IV therapy on the left. And on the right, we have on-treatment readmission. So a lot of these, 30-day all-cause readmission is kind of the gold standard metric for OPAT evaluation. On treatment is also important because a lot of these patients can sometimes be on therapy beyond even those 30 days. And so we want to capture a longer period of time. And so what you can see here is that in the pre-cohort, we had, in the all-cause gold standard metric, we had a 39% rate of readmission. And we cut that almost in half in the initial year of OPAT program implementation down to 22% or 23%, which is pretty much in line. Around 20% is in line with most modern OPAT cohorts of mixed indications. So we're really pleased with that. And I think it's, again, pretty obvious that that's an impactful intervention. And so then this also kind of demonstrates more recently and in an ongoing fashion how we track those metrics, and also demonstrates that we've been able to keep over time those same metrics within that relatively tight range. So again, looking on the left-sided graph here, so this is the same metric, readmission rate, all-cause 30-day readmissions. And that top red line, for those in the back that can't see, is the 20% rate that we talked about. And then we have kind of a stretch goal of down to 15%. And what you can see is in the last calendar year of 2021, we pretty much in all but 3 months kept our metrics in that tight range between 15 and 20% all-cause readmission. On the right, we also track infection-related readmission, just as a way to kind of look at the patients that are readmitted with OPAT impactable, for lack of a better term, readmission. So something related to their infection. We're certainly going to get, our share of GI bleeds and things that we really don't have any control over. So the metric on the right gives us an idea of how we're kind of doing with our patients and the types of things that we could have potentially intervened on to help. So that gives us kind of a way to adjudicate the patients and review those particular outcomes too. So in addition to kind of just general metrics, which again the hospital is particularly interested in, readmissions, we also do some other types of looks at interventions that we can do. And this one in particular was related to that initial vignette that I talked about, which was just identifying when the OPAT program started that there were a lot of patients where this kind of situation had happened, where it just became the default plan that if an ID plan was set and they weren't able to implement the ID plan as set, the patients would just stay to complete the ID plan. There was not a common plan of going back to the ID team, reviewing whether a change could be made or anything like that. And so just having the OPAT team there to kind of identify these patients early on, so you can see right away, within usually a few days that this plan that was set is not going to be one that's going to be able to be readily implemented immediately. The OPAT team, I was able to immediately kind of go in, start the communications between the primary team, the care transitions and social work teams, and come up with a plan that would be implementable. And so just from that first year of the OPAT program being active, we identified 17 episodes where we were able to intervene almost twice a month or so. And just intervening on those 17 patients, in adjudication, we're able to avoid about 430 days of inpatient stays and almost $1 million in inpatient stay offset. Another project that is kind of near and dear to my heart is really trying to look at patients who have substance use disorders, because they're another population that are really challenging to discharge, and I'm sure many of you are familiar with these types of situations. And what you're probably less familiar with is the amount of data that's accumulating that the use of OPAT in appropriately selected patients really has similar outcomes to patients who don't have substance use disorders. And so a lot of this data was initially developed at the University of Kentucky and Brigham and Women's in Boston, but they showed that over 70% of PWID will complete OPAT when you give them the right environment, you select the right patients, so patients that have already quit their IV drug use or who are interested in quitting and can be supplemented with either medication-assisted therapy like buprenorphine as well as other addiction psychiatry-related support systems. And so when you do all those things together, they really lead to much better outcomes. And so in the graph here, you can see this is a situation where oral antibiotics were used to prevent patient-directed discharges, because in these types of situations, I mean, you would think normally that, well, keeping a patient inpatient, that's a fail-safe way to be able to complete IV therapy. But in reality, about at least 20 to 30% of those patients will not complete therapy. You're holding them there against their will in some ways is how they look at it. And so they're going to self-discharge at some point during a long 3 to 4 week planned inpatient course. And so you're not really, if you can just facilitate that discharge in a safer way, you actually lead to equivalent success. And so what this graph in the bottom here kind of illustrates is actually the situation where you provide oral antibiotics to patients when they insist on a patient-directed discharge, as opposed to just withholding antibiotics, which is, I would say, what the common situation that we see occur and have seen occur in the historical setting is. And in so doing, you're actually able to, what this graph shows is kind of a discharge-free survival rate. That's very similar between patients that either completed intravenous antibiotics or were provided oral antibiotics during a patient-directed discharge. And that's, again, because you're going to see that 20% rate where patients, even when the plan is to keep them inpatient, they're not able to successfully complete that without leaving and then potentially having a worse outcome. So for our setting in OPAT, we've really tried to work with our addiction psychiatry team that we have at UNMC, who's really fantastic, to create a partnership between infectious disease and addiction psychiatry to help do all the things that I just mentioned. So identify the right patients, give them the right support, be that medication-assisted support, social work support. Sometimes that means inpatient substance use treatment, whatever's necessary to kind of coordinate all of those things to provide a safe and effective use of IV antimicrobial therapy in these patients despite their PWID history. Now, one kind of complicating factor I'm sure many of you experience and are well aware of is that probably more than opioid use history where we can use medication-assisted therapy with buprenorphine. Here in Nebraska, we have a much larger problem with the use of amphetamines, and we don't have that same medication-assisted drug that can help with those types of situations. And so we're actually actively looking at doing some studies on some alternative opportunities for providing OPAT in these types of situations, because it's a much more complicated and just difficult situation when you don't have that MAT that you can kind of help to rely on. Okay. Getting back to kind of some of these projects. So I've talked about a few of these over the course of the presentation, but again, in addition to looking at kind of readmission rates, certainly hospital administrators are always interested in return on investment. And what we've been really successful with is kind of preemptively working with our finance teams in our department and in the ID division department to kind of identify and kind of pre-screen these projects for cost offset evaluation, so that when we do that up front and we kind of get them to help us identify, here we're working on this project with, major discharges. Can you help us figure out, what do you think is an appropriate institution-specific cost for a patient day? And we found that in working actively and preemptively with the finance folks, then not only did, they're providing data that they believe is correct and appropriate to the institution, but then they're more willing to kind of back you when they're speaking in the C-suite about, oh yes, this project, I worked on it with them, these numbers are right, and then they're more likely to get buy-in from those people who are making decisions about adding resources to your team when you have that kind of support and preemptive look. So, in short, this is a couple of years of looking at some of these projects and the cost offset that we've identified with them, and our FY22 numbers are pretty equivalent. So in furtherance of kind of getting some of that support from C-suite, we've been able to kind of work through implementing and enlarging our OPAT team. So we have now a 1 FTE nurse in support, and then 1.5 pharmacist FTEs, as well as a 0.3 physician medical director for our team. And being able to kind of fill out that team entirely really gives all of our team members the ability to kind of do the best activities that are best suited to our individual skill sets and help us work at the top of our license. So I've kind of illustrated some of these here, which you can look at later, but I'll highlight quickly. So our OPAT nurse does a lot of the communications, both with patients and facilities, to identify what some of those impacts could be, or preemptively identify toxicities, and be able to then communicate to the rest of the team things that they identify. The pharmacists, as you might imagine, work a lot on identifying appropriate antimicrobial use, doing all of those stewardship activities that you would think about, as well as TDM and monitoring in the outpatient setting. And then our physician medical director does a lot of the outcomes evaluation, and then helping with some of the more complicated evaluations medically to ensure that we're providing appropriate care in complicated medical situations. And so I just want to end on trying to illustrate, hopefully I've done this throughout the presentation, but to kind of come back to the point that really OPAT and evaluation of stewardship at the transition of care is for everybody in every setting. And so if you have a larger hospital, I would submit that you should really start an OPAT program. It's, I think, really become the standard of care, and the IDSA guidelines related to OPAT would, I think, support that. But if you're at a smaller hospital and you don't, at the moment, have the resources for that, I think we've talked today a little bit about how you can engage your pharmacists, other prescribers, nurses, to do antimicrobial discharge review, whether that's oral or IV antimicrobials, to help with some of that, and then perhaps build some of the energy that you would need in order to have a more robust OPAT program. And the other thing that you can do is just evaluate through your safety system some of the OPAT-related readmissions that you've had. That can give you ideas for projects or other interventions that you might make in order to improve those transitions of care, again, which can be used to support other activities in the future. For those that are in SNF or LTAC facilities, I would say the things that I talked a little bit about us as an OPAT program, reaching out to those facilities to kind of ensure that they know the lines of communication. I would say if you're in those facilities, it's understanding when your patients come with IV antibiotics, who prescribed them, and how can I communicate back with those people. It's the Homeland Security mantra, if you see something, say something. And I think that we really appreciate that when we get feedback from our SNF colleagues that, this is really going badly, or I've noticed this thing, and so they just call us to discuss. It's really helpful. And I think it's also, especially when another thing that comes up a lot is that in the SNFs and other long-term care facilities, we'll have situations, especially when patients are discharged from larger institutions, the person whose name is on the order will not be the person who's actually running that antimicrobial. So we run into that a lot too, where understanding the providers that are writing for antibiotics in your community and knowing if that's the person that you really should call or if it's actually somebody else. So in our case, if we're discharging patients, you're going to get the name on an order of some hospitalist that was on service 2 weeks ago and is now in Jamaica, and you should really be calling us because we're in charge of therapy. That's a more complicated situation, but I think for many of your facilities, you'll know who in your community is the right person to call, and just ensuring that the bedside nurses or the physicians that are taking care in those facilities know who that person is to kind of facilitate communication. And then finally, just individual providers. We talked about understanding when OPAT is indicated, when it's not, and just ensuring in general, like we talked about, that stewardship at the time of discharge and through the transition of care is just something that's being thought about by the individual providers in as robust a way as possible. With that, I just want to thank a number of my colleagues, both in the pharmacy department, who I've worked with over the last few years to implement these programs, as well as in the ID division at UNMC, as well as colleagues and friends here, both past and present. I thank all of you. Happy to take questions. We do. So the question was, do we routinely utilize dalbavancin and other long-acting antimicrobials for patients with severe infections, be they complicated MRSA bacteremia, endocarditis, et cetera? And we do. And I can say two things about that. I didn't really put any of this in the talk, but we are part of one of the investigator sites for a randomized trial that's being done to investigate dalbavancin specifically as primary therapy for complicated MRSA or complicated Staph aureus bacteremias and all the other associated indications that go along with that. So we do use it within the context of the clinical trial, but we've also been using it outside the context of that clinical trial in situations like this. And actually, if anyone's going to ID Week or you're interested, we will have a poster at ID Week talking about our experience in that exact situation. So I'd be happy to share that with you in a few months. Yeah.